Good day. My name is Donnie Jardine. I'm the manager for the Medicaid Transformation Team in the Health Systems Division for the Oregon Health Authority. Today's presentation is on Home and Community-Based Services, or HCBS. I'd like to start off on giving a brief recap of the history of home and community-based services. This slide, which I will not go into great detail on, provides us with the history of home and community-based services from 1981 forward and gives us some historical context around the deinstitutionalization of those institutional settings for skilled nursing services available in home, as well as for individuals with mental health concerns and intellectuals with developmental and intellectual disabilities. I'd like to shift over to our current state of home community-based services. In January of 2014, the Centers for Medicare and Medicaid Services, or CMS, and issued further regulations which defined the settings where home community-based services could be provided in order to receive federal reimbursement and Medicaid monies. Each state in the nation did have to come into compliance with these federal regulations, and they needed to develop and obtain approval of a statewide transition plan. And this statewide transition plan really detailed the steps that the state takes in order to meet the deadline. There were several phases, which we'll talk about later, but to include within the statewide transition plan. And those phases included regulatory assessment, provider self-assessment, along with a member experience survey, the heightened scrutiny process, any provider remediation, and ongoing compliance to ensure that the state and other providers are compliant with the home and community-based services in the long term. Oregon did receive final approval of the statewide transition plan in February of 2019. You can find that at this conveniently located link on the slide. Oregon's Home and Community-Based Service Plan defines, describes, and aligns these HCBS setting requirements across three funding authorities, and these funding authorities are the 1915 C waivers, the 1915 I Home and Community-Based Services waiver, state plan, or not a waiver, state plan option, pardon me, and the 1915 K Community First Choice state plan option. For the purpose of this training and discussion, we'll be talking about the 1915 I state plan option. The purpose of these regulations and the subsequent Oregon rules was to ensure that individuals who receive home and community-based services through that state plan option received those in competitive and integrated settings. So they had the right to work in an environment that they wanted to and was appropriate for them, that it provided wages at a competitive level. It means at least minimum wage. They had the right to engage in community life, control their own personal resources, and personal resources, we specifically talk about money here, but that can also include a person's energy and their time. They had the right to receive the services in the community and in their home to the same degree as individuals who do not receive HCBS services. So just like you and I, individuals should have the right to come and go as they please with the appropriate or needed natural or paid supports. So one little reminder that states must be in compliance with HCBS rules and regulations in order to keep Medicaid HCBS funding, which is why we as a state have to ensure that ongoing all providers are compliant with these rules and regulations as well. As mentioned before, here are the phases of our transition plan. Phase one was the initial regulatory assessment. This is where the state had to go through all of the regulations, processes, guidelines, rules that were in place in 2014 and determine if they were in alignment with HCBS final rule and regulation, or if there were gaps in this initial regulatory assessment, and to identify those gaps and then come up with a plan about how to remediate any of those gaps so that the state with its regulatory processes were compliant with the federal regs. Phase 2 is the community education efforts. We do have a lot of stakeholder involvement, and this final rule did affect stakeholders and their providers and settings. And so we wanted to have an outreach where we could educate providers about the new regulations as well as our expectations around what those education efforts look around home community-based services. Phase 3 was our provider self-assessment and individual experience assessment. Providers had the opportunity to review their settings, their policies and procedures, and make sure that they also aligned with the state's rules and those federal regulations. And coupled with that provider self-assessment was an individual experience survey. So the individuals were offered to provide information about their experiences with their services. And we needed to make sure that the provider self-assessment and the individual experience assessment aligned, and those two matched up. And what the providers were telling us was what the individuals were experiencing. Phase 4 is the heightened security process. This is a process where if there is a setting that could be institutional based on where it's located on the grounds of a state hospital or adjacent to a state hospital and the like, that we had the opportunity as a state to assess that setting and determine whether that setting was an HCBS compliant setting or not. But further, because of where it was located, we had to document what we did as a state, submit all of that information to our federal partners, and they had the final review and say as to whether that could be considered an HCBS compliant setting. And then remediation activities. We had the opportunity to work with providers and offer technical assistance to remediate any gaps that they had in their programs so that they could come into compliance relatively easily and ensure they can continue to provide the needed services to our members. The last phase, phase 6, is what we are working towards right now, and we'll be planning over the long term, which is the ongoing compliance and oversight. We as a state have to ensure that our providers continue to remain compliant with the HCBS rules and regulations, and we do that through our licensing and certification partners. So here are some dates to know. Oregon, along with the other states in the nation, were granted an extension from CMS. Originally, all states had to be compliant with the home and community-based regulations by March of 2019, and what that meant that all of the providers needed to be reviewed, assessed, and engaged to ensure their compliance by 2019. After the federal government received information from states and providers, they determined that 2019 was a very ambitious date and that they extended that out to March of 2022. Our current timeline is to ensure that all providers are compliant with HCBS settings by June 30th, 2021. That will give us time to transition any members into compliant settings that choose to transition those, or bring non-compliant providers into compliant with our rules and regs. There are some areas to help with remediation that providers can have access to. Those areas are on-site reviews, where our partners at licensing and certification go into the setting and review the policies and procedures, documentation to make sure that they're compliant. Providers had the opportunity, as I said before, to complete a provider self-assessment so that they could scrutinize their own documents, policies, processes, and bring those within compliance. We do have our overarching Oregon rules, the OARs, and we do have a website with a lot of information for providers to be able to access, and that includes links to federal websites and guidance as well. Here are a list of the Oregon administrative rules of the OARs. Included the provider-specific rules, and these are located in Chapter 309, Division 035. And we have the 1915 HCBS overarching rules, and these are located in Chapter 410, Division 173. And then Oregon's HCBS overarching rules, which are located in Chapter 411, Division 004. All of these rule sets have a link to them for ease of access. We have our Oregon HCBS website, as I kind of mentioned earlier, the main page, subpage, and an informational page. You can also easily access these through the links or by entering HCBS Oregon or Oregon HCBS in any of the web search tools available. All right, we're going to switch gears a little bit and talk about the Home Community-Based Services rights component. Individuals have full access to and have regular opportunity to engage in the broader community. The setting in which an individual is receiving services include community access, so that puts some onus onto the providers to ensure that their members have the rights to access and opportunities to access the broader community. Providers have to ensure that individuals are not isolated. They have the opportunities to interact with other people with and without disabilities similar to their own. And that is beyond the facility staff. So the facility staff, while we recognize them and their status as a person, they're not considered part of the general public that the individual would have the right to interact with. Some examples are here. So we've listed going to the park, shopping, attending the community events and whatnot, going to barber or beauty shops for hair care if that's what they desire to do. I want to also indicate that the provider doesn't place any limitations on the individuals or their designated representatives, their ability to access their personal financial resources, personal spending monies, real estate, personal property, assets, etc. When I talk about regular access, I really want to talk about this means the opportunity for the individual to have meaningful input on the location in the community that they want to go. This isn't just we're going to be going to the local store down the road 3 times a week at the same time. They need to have the opportunity to say, hey, I want to go out, I want to go shopping, I'd like to go play around a golf or something like that. It's meaningful for that individual particularly. They might not all have the ability to do this independently, but they should have supports, either paid or natural supports in place that they can rely on so that they can choose to engage and have the opportunity to engage in the community. Regarding their personal resources, they may be safeguarded. So the individual may check their money in and out so that they're not inappropriately spending, or if they're working on goals to help with their financial literacy and whatnot, they have the ability to have some money and yet have some accountability for that. But they should not experience any barriers, and they should be supported through education and services in order to use their personal resources as they so desire to do so. For individuals who want to work, the provider supports and provides access for the opportunities to seek employment. We want to see individuals engaging in competitive and at least minimum wage or higher paying jobs as they desire or are able to. We want to ensure that individuals are able to control their own schedule, having the say of when they do things, what time they do things, and whatnot. This should be outlined within their person-centered service plan, which we'll be discussing in a later training. Services such as mealtimes, bathing, when to get out of bed, when to go to bed, etc., should be flexible, and they shouldn't have a set schedule around that. Just as anyone who is not receiving HCBS, you or myself have the access and ability to do so. And requests to engage in the broader community, like going shopping or to the movies, are routinely supported or accommodated. We should not be having any limitations to the individual's ability to communicate within the residential setting or with those outside of the individual setting. So I want to point out that individual providers don't need to purchase cell phones or minutes for residents, but there are times when an individual needs to have some privacy in order to use the telephone. The setting should have a landline or a common cell phone that the individual should be able to use so that they can have a conversation, a private conversation with friends, family, or like. I want to really point out here that the provider optimizes services and supports, not regimens, that they support the individual to make their decisions and their choices to live their life as independently as possible and not control those decisions and those choices for the individual. The individual's essential personal rights for privacy, dignity, and respect of freedom from coercion and restraint are protected. Educating individuals about the potential results of their decisions should not be presented in a way to coerce or to persuade a person to do the things the way you think they should be done. Individuals should have privacy in their sleeping or living unit. All individuals should have locks on the door available to them for the use in their bedroom, doors with appropriate staff having keys. I want to remind you that the staff needs to knock and engage respectfully with the individual, and they should only be using those keys in an emergency situation. And just like you and I, all individuals should have bathroom facilities that allow for complete privacy through the ability to lock the door or install. And individuals are free from coercion and restraints or seclusion. This should never be used as a punishment for an individual. The unit in the room is a specific place that can be owned, rented, or occupied. We need written agreements in place that gives the individual protections from evictions. And those protections include all of the timelines and references from the Oregon landlord-tenant laws. This section is only applicable to those individuals with shared bedrooms. If the individual shares a room, they have the choice of the roommate that they're sharing with. This does not take into consideration the residential setting as a whole. The provider still has the ability to choose who they provide services to or who they do not provide services to. There need to be methods in place for an individual to seek a new roommate should they desire one. So if they do have a roommate, we understand that sometimes those roommates are not always going to get along, and sometimes it's better to be separated from other people. There needs to be a process in place for those situations. So providers can use residency agreements to set any parameters around the requirement for changing roommates or requesting the change of a roommate. We want to ensure that people do have the opportunity to meet, to question, to basically vet any potential roommates that they have when they are introduced and come into the home. Individuals have the freedom to furnish and decorate their sleeping or living units. So we want to make sure that people can bring in their furnishings, posters, paintings, whatnot, and make that living unit like home. These people are living here. This is their home. We want them to feel comfortable and respected within their home. They may be able to secure pictures on the walls or use accessories. There may be an opportunity for them to paint the room a different color. The provider may put in a residency agreement if they allow them to paint the room, that the room needs to return to pre-occupancy a condition when that person leaves the setting. Individuals have access to food at any time. Individuals are provided 3 nutritious meals and 2 snacks per day. We want to see that individuals, if they want to, assist with menu planning and that the personal preferences are considered. I want to ensure that there are to-go snacks or heatable meals available if the individual misses a meal for whatever reason, or if they are going to work, that there is a to-go lunch they can go with. The individual needs to have access to personal food storage, which includes refrigeration, a freezer, dry storage, so that they can access that at any time. This doesn't mean that the provider needs to purchase snacks or food outside of the 3 meals and 2 snacks per day. It just means that the providers can't put any barriers into an individual spending their money to purchase their own snacks and have a place to store those food and snacks as they choose. Individuals are able to have visitors of their choosing at any time. Individuals living in the residence understand that there are no imposed limits for times and dates when visitors may be received. Individuals should be encouraged, just like you or I, to have visitors of their choosing and when they choose to have those. This does mean that the visitor needs to be respectful of the rights of those living in the residence. The providers still need to maintain a safe and respectful environment for all of their residents. The expectation here is that the visitors comply and are respectful with regarding noise levels and other reasonable expectations in order to stay and visit there. And the other thing we want to point out here is that the visiting is not an opportunity to stay indefinitely in the mechanism for another person to move into the facility under the premise that they're just visiting a friend. The individual choice regarding services and supports and who provides them is facilitated. Choice and preference of providers should be documented and respected. For example, a grooming and hygiene tasks are completed in a way that is both respectful and comfortable for the individual and the staff member. The setting is a physically accessible and offers a home-like setting, such as having full access to typical home-like accommodations, the kitchen, dining area, living room, etc., laundry and bathroom. Access to all public areas of the residence are available to the person who lives there. And it's important really to remember that staff are working in these people's homes. The next few slides we're going to talk about are individual-based limitations. We'll talk more about these in a future training, but you can find these in our Oregon Administrative Rules under Chapter 410, Division 173, Section 0040. We understand that there are limitations of Hcbs rights that may be required due to the health and safety risks that an individual is presenting. These are determined on an individual basis, and the person has to consent and give written and verbal agreement to that limitation. So there may be an IBL when there's a significant health and safety risk to any one of the requirements that we've already discussed: access to food, visitors, lockable entrance doors, choice of roommates, furnish, decorating, individual units, control of schedule activities, and privacy in their individual units. There are some requirements for applying IBLs. There has to be health and safety risk. This does not apply to perceived risks of an individual. There needs to be some documented and sustained history of health and safety risks. IBL is supported by a specific assessed need. The individual or their legal guardian or representative consents, agrees, signs, and dates the IBL. The IBL is directly proportionate to the assessed need, and it will not cause harm to the individual. It's very important to determine if the risk can be safely and effectively addressed through skill reintegration building versus an IBL, or limiting any of those setting requirements. So the provider needs to demonstrate and document the specific and individualized assessed need. They need to document what prior positive interventions and supports were used and why were they unsuccessful. documentation of prior, less intrusive methods, a clear description of the IBL directly related to the assessed need, timelines for periodic reviews, informed consent of the individual, and assurance of no harm to the individual. Documentation is vital with providing services, and it shows the current status of the individual. Documentation shows whether the IBL is still needed at this time or whether it can be removed safely and effectively. The IBL should only be used as long as it is needed and no longer. And the provider really needs to ensure that the skill reintegration is occurring at the same time that the IBL is in place to work on replacing some of those health and safety risks with more constructive and positive approaches. So at this point, the provider needs to maintain and to copy and document all IBLs. You need to collect documentation for the purpose of reviewing the ongoing effectiveness of the IBL with the independent qualified agent as requested, and they'll request the IBL from the IQA when a new IBL is needed or when that IBL needs to be changed or removed when it's no longer needed. Then the IBL submission process. The IQA and the provider is going to work very closely together to document all the IBL needs and the processes. But they need to, together, there's going to be the identification of a need for an IBL. The IQA will receive the request for the IBL from the provider, and then they'll need to gather the required information to complete the IBL form. The IQA is the one that is going to go out and obtain signatures and consent. The IQA is then going to go back and update the person-centered service plan to include all the required documentation. And then they'll submit that form to the provider. The provider will need to file and keep records of the IBL form. At this point, the IQA and the provider are going to be collecting data and reviewing the ongoing effectiveness of the IBL. And the IQA will be involved when the IBL is needed to change, when it needs to be removed. That needs to take place at least annually, but it does need to be reviewed periodically. And then the IQA will remove the IBL when it's no longer needed or appropriate. So we do have some additional information here to provide for providers and stakeholders. We have our home and community-based service settings for those, our statewide transition plan. We included an Hcbs fact sheet and the information sheets. There are frequently asked questions that are available on that site. We link to other websites which include the federal rules and the CMS's Medicaid webpage, and those are all found towards the beginning of this presentation. If you have any questions, comments, concerns, please contact us. We have a new email address. It's ffs.bh@dhsoha.state.or.us. Again, ffs.bh@dhsoha.state.or.us. Thank you very much. I appreciate the time that you've spent with us today. Have a great day.